You suffer from Batman. All right, ladies. How's everybody doing today? Doing good? Positivity.
We're alive, we're here. That's positive. I'm alive. I could be dead.
Positive.
I could
We're
be
alive.
dead.
I get to breathe today.
Ah,
All right. But, so mainly the meeting today is supposed to be for radiology training, so we can get like more familiar with how to position for certain type X-rays, like the post-op ortho X-rays that we need to take, or if they're coming in for limping, they have to have things at a certain position, angle, and all of that. So Dr. Dolan is going to hit that up, but he's still in with the dental. They ain't very close to being done, but until they're ready, we're just gonna go over a couple things. So, I don't know if you guys saw that weird little sheet over there in the lab area for the images. I meant to grab it before I came over here and got it.
Is it following here?
This is what I'm referring to.
The thing that was kind of hidden.
Yes. Because I didn't want it to even, I was gonna make a post and I'm like, we're about to have a nurse meeting, I'll just go over it. So this was given to us by, what was her name? I can't remember her name. Well,
The Zoetis technician.
yes, the Zoetis rep. I cannot remember her name right now, huh?
Andy?
Maybe, I think this.
She's got like one side of her head.
I thought her name was
I
Andy.
think so. I think you're right. I was gonna say Angie, but
I thought it was Andy.
I might be Andy. But yes, she gave this to us because apparently there's a challenge. And you get to claim your prize or whatnot. What did you say the prize was?
So once you fill out all of those, which they'll comp like 2 or 3 of the ones that we don't have,
Mhm.
of each. But they'll do a pizza party and then they'll also send us like dog toys that are
That's right.
branded, like Zoetis branded ones and like some others that we just.
So
So what?
this
is it?
was for dermatology. So we, everything here we've already completed. All the stickers are done for this. So this is for AI blood smears and AI urine sediments. So we do have the capability to do those on the images as well.
So like running a urine sample?
Like a sediment. So we have to actually spin it down, get the sediment, put it on there like we're running a manual, which I don't know if everybody knows how to do because it's not something we typically do. So we do need to try to do those or just, let the doctors know if we have a urinalysis is being run, hey, we can just try it and do it as a comparison too. If it's somebody you dropped off, it'll probably be more ideal because I have no idea how long it's gonna take. So, but yes,
It
it
takes about the same amount of time with people.
it's fecal, okay.
Yeah.
Okay, that's what I was like. I don't think it should take that long, especially just being a urine sediment, because the sedative works pretty fast too. But there are guides on Zoetis website to learn how to do these tests. But like you said, they will comp like 2 or 3 of these, 2 to 4, I think. But yeah, they'll comp some of these, so we don't have to worry about being charged for some of them, just so we can try to get into the habit of using these to see how they work and see if we like it. And once we do them, just place the stickers on there. If we're done, just go ahead and scan the code and claim the prize, same deal. Or you can just bring it to one of the managers and we'll get it done for y'all. But the stickers are with it, little happy, creepy urine stickers, and then little blood droplets. So just put them. You got one what? Well, the little urine droplet. So yeah, that's it for that part of it. Now, as far as the images goes too, we are supposed to be. She also let us know we should be cleaning that stage twice a day, as much as we use it. I don't know what that was. But we should be cleaning the stage twice a day. Does everybody know how to clean the stage?
Alcohol and then those little glass pots.
Yes, and afterwards we'll use distilled water too, so alcohol, white. And she said that she's got the Kim wipes that we can use or lens paper. Either one. But make sure to do that twice a day, which is that's been added to the checklist. I didn't put the new checklist out because I was like, we didn't go over all the stuff yet. So I'm sorry, I just realized I was missing one of the spikes. But anyways, Yes, I did not add, print the checklist yet, but I should print them today. But I want to go over that first. So I think that's it for the images. Oh, and as far as the images, ear cytologies. We all know that sometimes we get those, run them, and then we get nothing. So she also said, if you stain an ear or a slide from ear cytology and it does not appear to have that much stain uptake, don't even bother putting it on the images. Read it manually, because most likely it's not going to pick up anything. So, that was like, that'll probably make a lot of people happy. Like that. But definitely just keep that in mind and let the doctors know too, that was a recommendation for the Zoetis rep. If there's any confusion as to why didn't you use the images, just say, well, the Zoetis rep told us we should read it manually. The thing that I took of it. That is it for the images. There was nothing else she mentioned that I didn't go over, right?
I don't think so.
Okay. Okay. All right. And then just straightforward nursing stuff. Just we have to make sure everybody has water. Because there were a couple days last week or the week before where there's patients didn't have water like all day long. And it's when Tabitha was still here because she made me aware of it. But one of them was a diabetic one that didn't have water. So that's definitely number one. They should always have water. But any patient should have water if they're here with us for the day, unless they're vomiting and you can ask the doctor if they want us to put water in there. Most of the time they'll still say, yeah, I can choose water, but just ask if you don't know. But ideally, everybody should have water. As far as callbacks go, when we are working from the briefcase, Dr. Beatty wants us to make sure that we're just making a list of the ones that we are contacting with lab work, because the papers end up just sitting in the bin, and then we have to go back for just checking the computer, seeing that 90% of what you're checking has already been done. It's just a waste of time. So that being said, just make sure if you're doing it from the briefcase, not a problem. Just write and have a little piece of paper beside you, write the name and test code on there to remind yourself to go back and find the papers later. That way we just stop wasting a lot of time sitting at the computer, not really being productive. And then when you're floating, just remember, check the rooms before, sitting down to do any callbacks or whatnot, and be on standby for your primary nurse, which I feel like everybody's done better about that for sure. It's just, this was something I wrote down before. I noticed a lot of improvement with it. So thanks guys for that. But just as a reminder for everybody, and just in case somebody is not here, fill prescriptions, clean rooms. Those are the number one priorities prior to sitting down to do a callback in between appointments. But always, yeah, if you can get a callback done, awesome. Dr. Gravesi actually made this suggestion. I think it's a great idea because how many times I get ready to use the ear cleaner and the top of it is dirty, like the tip, it's just nasty. So we want to make sure not to use the tip in the patient's ears in. So we're just taking a lot of cotton balls, soaking it down and just squeezing it down. A lot of people do that anyway,
Yeah.
but not everybody does. So we're trying to make this a standard across the board for everybody to start doing.
Well, I also always thought, like, if you take the bottle of cleaner, and I could be completely wrong, so correct me. You take a bottle of cleaner, you put it in a dog's ear and then you squirt it. That's a whole lot louder and scarier than taking a cotton ball, putting it in the air and then pushing it like
you're
that.
good.
So I feel like, I know that like, that's how like some people direct clients to do it. I just feel, they're like, oh, it's not scary. And I'm like, I feel like if I was a dog, I'd be there.
Yeah, because
If like a bottle just comes in my ear and then it's just like,
I agree.
water.
You could just take a wad of cotton balls, squeeze it
and
down
then
in
just
there.
like put it in there and then squish.
Do you have a dog here that can be used for like a good dog?
No.
I was gonna bring Delilah today, but I didn't have time. There's
I
no
don't
dog here?
think
Not
so.
really.
Because Callie,
Not that
Callie's
one.
a sweet dog, but I think she's too squirrely. She ain't gonna tolerate that.
Right.
And Maverick is
That is-
fragile.
He's quite failing.
It's you, Bailey.
Let's do it.
They're all there.
Yeah, we don't have a dog.
I maneuver my legs and how he wants to stifle photos.
I don't know if they have anybody good over there in pet care we can borrow.
if we have a really good dog that would just like sit still, it would be
On
great.
this side,
Okay.
but they are
I can ask
also
about that.
napping,
Hey,
so keep
you
that in mind.
Oh, never
You
mind.
take one, you're gonna wake up every
I
time.
forgot it's nap time.
You don't want to make my legs just position how you want.
I really want other nurses. They're almost done.
Okay, yeah, cause I was like, they're the ones that need to see it the most too, cause
It's too fragile.
Whenever you guys can, whenever.
we'll just keep rolling with some other stuff until, unless he's,
Put me in it,
you want me to just keep rolling with other
Yes,
nurse
keep
stuff
rolling.
until?
You got some more nurse stuff that you wanna go
Just a
over?
couple things,
you can
yeah.
Go over all your stuff and not.
Okay, yeah, I was just going over what I could and then I'll hype up the rest later. Okay, let me see. All back. Oh, yes, yes. So the reason for doing that was just to minimize the risk of spreading infection, because Dr. Vesey thinks that's how Teddy ended up with his ear infection. Because the tip was dirty before she got ready to use it, she wiped it as well as she could, but of course, if the outside's dirty, the inside probably was too, and you can't get everything out of there. So she was like, there's no reason for him to have ear infection, he would get a bath, but that's potentially, we might be spreading ear infections that way. Okay, let's see, the callbacks, just make sure to handle callbacks the same day. Even if it doesn't seem urgent, even lab callbacks, don't push them to the next day, because it's been noted that things are being pushed, because we'll have results typed in like from a few days ago, and then all of a sudden seeing like the next day we're checking, it's like, wait a second, why wasn't this here yesterday if the callback was put in at this time? So definitely want to make sure that we are checking the callbacks, handling them the same day, even if it's not urgent. On the same note, we want to make sure to, push the callbacks to the next day if you have made contact with the client, and it's something that you need to follow up with. So you don't have to leave it pending for that day if it's something that you just got to follow up with again, and just go from there. The other thing was, and that was exactly what I was about to mention, Katie, surgery callbacks. We absolutely have to make sure that we're doing those on Saturday. I don't know why, but for 2 weeks in a row, they've gotten skipped over. It's on the checklist, and turning oxygen on is on the checklist too. Both of those have been skipped over on Saturdays, the last 2 Saturdays. So I don't know why, but I don't know if people aren't comfortable with doing the surgery callbacks. Is everybody generally
I did not know
comfortable?
we were supposed to be doing that at all.
Okay, yeah, so it's on the checklist for Saturdays. And we should definitely make sure we get it done. Now, as
Most
far as,
Typically, like, checking and seeing how the pet is.
yeah, that's
Very
it.
easy, it's quick as possible.
Right.
Yeah, you
It's usually
literally
like
just,
checking and seeing how they are.
yeah, you call, ask how they're doing post-op, make sure, if they had a surgery. If they had a surgery, the incisions are
I'll call you daddy.
looking good, no swelling, drainage, anything like that. Eating, drinking, no vomiting, diarrhea, any concerns at all that we need to address. Ideally, it's best to do those earlier in the day in case there is something pressing, because people don't realize that something might be a problem until we call them and they're like, oh, I didn't think it was a big deal. And then we're having to deal with that crap at like 12 o'clock. So ideally in the morning, it's best to call the anesthesia callbacks. Let's see. I think that was pretty much it. Yeah. You're distracting me, sir. When we're checking voicemails, make sure that when we save messages. If you're saving messages because you can't understand what somebody said, just let another nurse hear and see if they can decipher what's being said. Because sometimes people speak too fast or they have a very thick accent and you just can't understand what's being said. Not a problem to save it, but just make sure, the same day you try to have another nurse listen and try to resolve it instead of saving it and not letting anybody know. Additionally, if you're checking voicemails, check the saved ones as well, because people might forget to let you know that they saved something and they just sit there for days. But most of the time, the saved ones are the ones that are handled already anyway, but just in case.
Can't understand them, or you can figure out the meds that they want, when they and it starts to go first voicemail rather.
Yeah.
If you hit 3 really quick, it's then it will go back and it'll say, message from, and then it tells you the whole phone number
Mhm.
on who they called you from. So you can't, you can get like the meds, but you can't get the name.
Yeah, you can.
And
use
at
phone
least we'll
numbers.
give you their number on who, like,
It's
who
like the
called.
message envelope.
And
Yeah,
then you can kind of decipher that one.
Yep.
That's also kind of thing like helping that.
I agree. I agree. All right, and then I know you guys have seen some changes to the locators recently. And we've got the check-ins for pet care, and we're doing that regardless. If we have medical borders over there, and we're just gonna make sure we're always checking at those times, regardless if anyone's over there. Same thing on weekends, we're checking in with them, even if they don't have a medical border, just to make sure there's nothing changing. Like today, for example, Lucy was fine, but then they came to me with a concern about a cat that wasn't eating for 3 days. So then I just wrote him on the board just as a reminder, hey, check in with him, see what's going on. And we're doing entice for him. So hopefully we'll get him eating with him. I added something else. Me and Kristen talked this over. Drop off estimates. I don't know, some of you probably weren't here at the time. But when we used to do estimates for drop offs during the rounds at one point, I don't know if y'all remember that or not. Okay, so at one point, when we were doing rounds, we would do estimates as well for whatever patients were being dropped off.
Was this like a decade ago? But I never,
No.
that was a thing.
That was a thing.
When we did rounds, I never did that.
It was a very short-lived
I was gonna
thing.
say, that had to have been way before I
It was-
ever got to do rounds.
Yeah, it might have been. I thought you were a nurse at that point, so I don't know. And this may have been before you got here. I don't know, but at one point, do you remember that, Katie?
When
We used to make
when we did
estimates
rounds.
for the drop-offs when we did rounds. It was a very short period. Okay, that's what I was like. No,
Elbow says she would have.
Wasn't a
We've
fever
been
dream.
in the same number, she's been nurse.
Yeah. But yeah, so we did do that at one point. So that's another thing that we're gonna start doing is have someone do the drop-off estimates. So we're gonna have a nurse assigned to do those things, and it's gonna be basically done during the lunch hour. So we've got to added this down here to complete the callback, pet care consents, and drop-off estimates at that lunch time frame. It's not the same person doing all three, just so y'all know. It's just a different person delegated to these tasks. So whatever task you have, like, nurses, everybody works on the callback. Whoever's assigned to pet care consents and the drop-off estimates would be assigned to do so within that 2-hour window. And that's, I think, the biggest change for that. And then Saturday's locator was a little bit different looking too. But she just revamped it to make it clearer about the times to check in or whatnot. And then, yeah, same thing with the drop-off estimates. Someone's assigned to that too. So is there any question?
On the side though, it says like who floats, who's with doctor, who's with the doctor though, right?
Yes, yep, it still says rooms, consent, exam nurse, float, treatment nurse, that kind of thing is still, yeah. What'd you say?
What do you mean by the drop off estimate? Is that for like phosphate stuff? Is that for what
Any drop.
Cost, any drop-off.
you have to? Like,
Because
go
we
to the
have to do-
doctor and figure out what they want.
Yeah, or you can just make a general estimate for things. So, you should just make a general estimate for whatever's they're being dropped off for. But if you can't, if it's something more involved and you don't know what it might be, just go ahead and ask, the doctor what might be needed. So yeah, just follow up with the doctor, see what they need or what they think might be needed and just make an estimate based off of that.
Is that to like expedite?
The check-in, yeah.
Does that mean CSRs could do it?
If it comes down to it, but ideally the nurses still should be the ones checking in, the ones that aren't HACCPs, because we have additional medical questions we need to be asking them. So the nurses still need to be the ones checking in if we can, but if for some reason there's some craziness and we can't, at least there's an estimate made and we can just go from there. Yeah, so we're starting that back up again. I know apparently it was new to y'all, for sure. I couldn't remember when it started.
I didn't know that was a thing.
Yeah, so I was
I
like,
mean, I was just like a warning of, but like, it was just like a realizing, oh, there's no estimate, so then you're rushing. You're like,
Yes.
okay, you're out an
yeah,
estimate.
and it just creates a lot
Yeah.
of extra work in the morning. Sometimes you can't find the doctor or they're not here quite yet when they're checking in and
And
it's
you're
like,
just kind of like putting whatever you think.
Yes, we did it when we scheduled drop off appointments too.
and I thought about that too, but then we're not the ones scheduling it 9 times out of 10. and then they can't make the
Well, the
estimate.
doctors do what they.
Yeah,
Yeah,
they can, and ideally, that's what was supposed to be happening, but sometimes it doesn't, so. Just we're the double check point. Make sure we're doing it on our end and then checking with the doctor, but that's pretty much it, since they're out, I'll just. Stop it there. I'm good.
Is anybody on here or are we?
I'm just recording.
Recording.
Yeah.
So I didn't know if I should stand in front of them.
Nobody's there.
I'll stand this way. All
Thank
right,
you.
great.
Hey, just so everybody knows, because we've got your walkie off, Siegfried and Madison is not at the 2 o'clock hours.
Okay.
So whatever we need to work on.
Thank you.
Well, we got like 35 minutes or so, but I can talk about radiology all the time. It's one of my big things. So, I would like part of this to be here, and then maybe we can go over to the radiology room. And I was gonna look for a dog. Maybe we can take that little Boston. I don't know, he looks old and stuff,
She
but
is
like
13.
Oh,
13.
yeah, I mean, we can just use her to sit her on the side. But today I'm gonna try to cover like every little things like with collimation and KBP and all that, and then but really focus on positioning. And I want it to be interactive. So first of all, when you go to radiology, please always, and I know everybody's pretty good with this, but please gown up and just be safe. I mean, we take it for granted because it's one of the things you can't see. Like you can be radiated and not feel anything and not really think it's hurting you, but we got to be safe. So styrene shields, the aprons, which are getting new ones. We've got new ones, and then badge, and never get your hands into the primary beam. So when we talk about like taking the film, you do measurements, and then we set it. So we have KVP and MAS. Who can tell me one of what KVP is or what MAS is? Anybody know? What is an X-ray machine? Kind of. What is it?
Dark
Since wavelength removal, so we get a picture of the enzymes.
Yeah, so it sends X-rays, so it is kind of like a camera, right? And so just like a camera, you have different settings. And so the KVP is the strength of the X-rays that are being sent. So the higher the KVP, it's called kilovolt potential. So when you make a potential with a space in an electrical field or electromagnetic field, the potential that's the higher energy. So the higher the KVP, the higher energy. What that means is that it'll get through something. It's like shooting a gun through a piece of wood. If you have a handgun, you shoot a piece of wood, it's going to go right through it, right? So an X-ray that's more powerful is going to go through more stuff than if it's less powerful. Okay, and then MAS, what is that? Pretty much. So MAS it's not exactly shutter speed, but it's like how many. So if you have less power and you hit it once, but then you have more and they just keep hitting, you're going to get more that penetrate. So KVP is how strong the waves are, how strong the beam is, and MAS is how many waves are going through, and that can help with contrast. So if you were to get a really powerful wave and you shoot very short amount of time, and you have like bone and then you have other stuff, what you're going to end up having is you're going to have a very black and white photo with no gray. But when we're reading certain films, we want lots of gray because we want to see all those things in between, right? So so can you tell me what if I shot an X-ray, and in old school it was a film, now it's a digital thing, but if you shoot an X-ray and there's nothing there, what color is it? Black. It's black. So black is fully exposed and white is not exposed. Okay, same thing like if you exposed film to that light and then it would just be black. So that's why things like air in your lungs are more black. So of course the table is black, and then it should look black when we do it because we want to have enough speed. But then the air in our lungs is black. If there's gas in the colon, that's kind of black. I mean, so those things. But then as you move up the scale, it gets grayer and grayer until you get to bone, which is kind of white, and then you have metal. If you have a BD or you have something they swallowed, it's metal, or the tag, it's white, right? So all those things that has to do with when you're shooting the KVP, when you take the measurements, we don't want it to be like super black and white unless we're really just, if we're looking at bone, it's more important. And that's why actually with most knees, I just shoot them at 90 and 2.5 and not 80, even if they're a smaller dog, because I just want to get a really nice picture of the bones. I'm not as worried about the soft tissue. We'll see the swelling in the knee, but really that's the KVP and MAS, and that's why we have those measurements, is because you want a film that has enough power to get through the animal if it's a big fat animal, but you also need to have the proper MAS to have nice gray contrast, especially when we're doing the abdomen or we're doing a thorax. But that is, the higher the MAS, what can happen with higher MAS? If, let's say you have a dog you're taking a chest film of and you have higher MAS because they're like big and fat.
Overexposure.
What happens with shutter speeds and cameras if you have a long
Oh,
shutter?
it's a blurry, doesn't it?
Yeah, you have motion artifact. So you're more likely to get motion artifact if you have a higher MAS. So if you have a dog that's panting and the MA, because again, you're shooting more out. So it's a matter, it's like how many are going out in a period of time. And so if you're shooting them out and they're panting, then some of it's gonna look blurry. So that is a negative about higher MAS. But if they're sedated, it's best. If they're panting very heavily, we might get motion artifact. So that's kind of KVP and MAS to understand that. And they're both important. But KVP is really what gets you gets through and makes a picture, and then the MAS is kind of like making it more contrasted if we need it. So then collimation. Who can tell me why collimation is important? There's a couple reasons.
Makes the image more clear.
So yes, if you want to focus on one thing, a good example is with a cat. Like, we don't take catograms. You can, it'll fit on the picture. But the reason you don't want to take a catogram is because you're really trying to focus. If we're trying to get as much information from a two-dimensional black and white X-ray, we want it to be as clear as possible. So that's number one. What's another reason? Correct. So for whom? Correct. Less radiation to the animal that's unnecessary. Like, we take it for granted. Again, it's like we X-ray an animal, big deal. Like, we're not putting a lead thing on them, whatever. It's small amount. They're not getting that money exposure, but it's still exposure. So radiation to the animal and radiation to ourselves by something that's called scatter radiation. Who can tell me what that is? It's the bounce back. That's right. So the X-ray, if you beam it like this, it's gonna be nice and focused. If you open it way up, it's going like this, and you get some like the rays will hit and they'll bounce off and they'll scatter and they'll hit us. So scatter radiation is the way we get exposed to the radiation there, and that's why we're gowned. So if you're gowned up and your hand is on the beam, your exposure risk is very low, but we monitor with the thing. So that's very good, because we have to, because we're exposing ourselves to a lot more radiation than the average person. One thing we don't use is eyewear. If you take the film, it's good to not look directly at it if you can help it, but there is eye protection too. But as far as general safety, just wearing that and not being directly in the beam and collimating appropriately is safer for everyone. All right, so that's my spiel on that. We've got the settings and protection and collimation and why that's important, why we don't take catograms or diagrams if possible, doing the best collimation necessary to get a good film and to be safe. So then we talk about positioning. So let's start with the easy ones, the thorax and the abdomen. It's really, I feel like we should have an animal for this, but who can tell me
I'll be the animal.
let's get this Boston Terrier out.
She has swollen face.
Oh, she's fine. She's fine. I'm not gonna torture her. We can have her even stand up.
Hey, before we go in there, quick question.
Or we could just do it out here, I guess, if we don't, yeah.
How do you adjust the film or the settings if something's too light or too dark?
So if it's too dark, then what does that mean? Well, contrast is one, but if it's too dark generally, what have we done? Remember, a fully exposed film is black. It's too high. You're overexposing it. So you need to cut the KVP down. You may have to cut the MES, but generally you just need to cut the KVP. And so then if it's too light, then clearly you don't have enough. I think the only time we run into a problem is when we have big fat animals and we're trying to shoot an abdomen and it's too light and we turn it up all the way to 110 and 10 and it's like still light. Our machine is limited to whatever the algorithm it has. So sometimes we just have to say like it's the best. You can try different settings. You can try to decrease the MAS and see if that helps just like get less contrast. So you kind of have more clear like black and white versus it being all just kind of like gray. But if you have a great big fat dog, you know, and you're taking an abdominal film, sometimes they'll be a little underexposed, but you can only do the best you can. So if it's too dark, you got too much KVP. It's too light, increase KVP. If that doesn't work, you could try MAS to just have more go through it. That could work. But 110 and 10 is our highest setting, and I don't think you can really, you could try go a little higher than that. But anyway, that, am I blocking this the whole time?
No, you just got there. I was trying
So,
to see if it was still recording.
So yeah, so that's, does that answer it good enough? You think?
Yeah,
Okay.
I think so. I just wanted to make that clear because I know. the
And
question
you
comes up
can't-
a lot.
You can't go lower than 80 and 2.5 on our machine. If it, you know, with bone and like small dog legs, I'll usually even just go to 90 and 2.5 unless they're really little, but you cannot move that MA thing, please, nobody. I've seen it touched. Please don't move that one that has the 300S and the 100S. It's got to be on the mark. It has to stay there for the algorithm of our digital X-ray. Otherwise, you will get weird things happening. So please don't ever change that knob. But the major and minor KVP and the MAS you can change, and you can fiddle around a little bit if you're having trouble, but generally the chart works. We have some limitations to great big fat animals. Landmarks. I'm gonna ask Sarah. So I'm gonna put you on the spot. If I'm taking a chest film, what is your cranial and, oh, can I please, before I even put you on the spot, I'm gonna talk about naming things, like, because we have AP, VD, you know, so AP and PA are human terms. However, that's what we use because it's easier than saying CC, because what is CC? You know, cranial caudal. So AP is anterior posterior, right? So if I'm taking a film of the leg, which it's the only time that it applies is when you're taking their legs. AP means the beam is shooting from anterior to posterior. So that would be if I had my forearm like this, anterior to posterior. So that's really cranial caudal or dorsal palmar is actually another thing, which is another positioning technique. But if I say AP, that means that the way the beam is going is from the front to the back. If I say PA, that's from back to front. So when I make you do a PA stifle, which is a pain in the butt, it's going from back to front, which is caudal cranial. But that CC is a lot, you know, I have to say caudal cranial, but we use PA for that. Obviously VD, ventral dorsal. So when we're taking thorax and abdomen or skull, ventral is here and dorsal is here. So that means it's going from here to here for VD, and then DV, if it's a heart patient you want to put on their back, just set them down on their sternum and it's going dorsal to ventral. Okay. And then lateral is self-explanatory. Skull films have some different things when we do like oblique films and such, but just know AP, PA, VD, DV, and then if I say what is the other? Does it have like dorsal palmar or it just says AP on it? Yeah, so that's, we don't have to talk about that. So that's why we use AP and PA, and that's what that means. So we were talking about position. So if I say, Sarah, I need a lateral of the thorax. Well, let's say I need to use thorax. What are your cranial and caudal landmarks to take that film?
I know on the X-ray, it's gotta be the diaphragm if you're going chest.
Well,
Tip of the shoulder blade to the sternum, isn't it the sternum?
So-
No, sternum is up here.
this is exactly what you want. When we're taking a skull,
And
taking a
everybody sees.
thoracic film, it is the thoracic inlet, which is right here. So just the point of the shoulder or the thoracic inlet, where you can feel it like right here. So that's where you want to have the cranial aspect, right? And so you're gonna pull their legs out of the way so that we can see the front of the chest when they're laying down. But when you're having the beam, you can feel the manubrium up here, like this bone, right? So that's gonna be the cranial extent. The caudal extent. If you were to just go to the end of their sternum,
That's not-
you're gonna cut off the dorsal. If you guys picture in your head, the diaphragm is like this, right? So you have on top all this lung, and on the bottom, oh, you maybe you get an X-ray pulled up or what?
No, I'm just getting
And on the
closer.
bottom, you're gonna have the liver. So, you know, you have to go kind of into the part of the abdomen. So what you do is you feel the back, you know, to the xiphoid, the end of the sternum, and you feel the back of their rib cage, right? So you put your thumb on their sternum and your middle finger, your ring finger on the back of the rib cage. The caudal extent is the midpoint between those two, okay? So when you take the film, that's where you're going to be the caudal extent. So it's the xiphoid with your thumb, the last rib with your finger, and the middle is where the caudal extent is going to be. And that should get the full lung field in the back. Okay. If you happen to cut off a little of the lung, just make it a little bit bigger. But that's how you do it. Thumb, middle finger, go in between, and that's about where the caudal extent of the thoracic film is going to be. When you put them on their back, it's the same thing. You just kind of shoot for the same, but you're going to make it more narrow unless they're super fat. When you put a dog on their back, they're definitely more narrow than they're wide. This way, so you kind of narrow it in, and then you pull their legs up. It's important to get their legs out of the way so that we can see that lung, the cranial lung, on the lateral film especially, okay? Things that you want to look for is it straight or not? Is it the ribs should be relatively lined up? And so I should have just like pulled it up here, but like the ribs, you shouldn't have like the top ribs way like this and the bottom ribs like this. They need to try to overlap. And you can also look at the vertebrae and make sure that that they're pretty much straight up and down. And when you get them on their back, you want to see the dorsal spinous processes. They'll just look like little diamonds if they're straight. If you're seeing the thoracic dorsal processes out to the side, then they're tipped. The trick is you look for, when they're on their back, you look for the sternum and you see which side is it pointing towards. So like if I'm, hold up, so much easier. If I'm looking at the film and their sternum is over to the right and their spine is over to the left, how are they tipped?
Works that way.
Right. They're tipped this way. So if their sternum and their back are not lined up, they're like this, that means they're tipped this way. You want to go like this. And so that's how you tell it when we're doing a VD, because this is the top. And so we know that it's leaning this way. So if you're trying to say, is this straight? Look, where's the sternum? Can you see the sternum? Is it totally lined up with the backbone? So you can't really even see it hardly. Then you know you're straight. The heart may or may not be right in the middle. If they've been on their side for a long time, they flip on their back, it might be tipped to one side, but that's going to tell you if it's straight. If they're slightly like off center and it's kind of curved, but like, so now their chest is like pointing a little this way, but it's straight up and down. I mean, if they're not, that's still a straight film. So if we can look at the chest, even if it's not straight up and down with our rectangle of our viewer, if it's straight like that and it's not like too twisted, then that's still straight. Obviously we like to get them all in a straight line, but sometimes it's not possible, or we're trying to do it quickly because we're worried about their breathing. If they're straight up and down and their lungs are up and down, then that's a straight film. So that is the thorax. We might ask for 2, we might ask for 3 views. Why are 3 views in a thorax sometimes important? Which one? Which lung do you see clearest if I do a right lateral? The upside. If I'm doing a right lateral, the beam is hitting the left lung, and then it goes through, and then it hits. Then you've got the heart, and then you've got whatever's behind the heart that we can't see because the heart's blocking. So, and it's down and it's collapsed. So whatever is, or partially collapsed because they're laying on their side. So whatever side is up is the side that we're seeing the best. So if I'm just doing x-rays because I want to see if the dog has a big heart and just making sure they're not in heart failure, I might just want 2 views. But if they have any lung disease, pneumonia, cancer, even fluid in their lung, we're going to probably get 3 views. And some places only do 3 views because you want to be complete. But there are times when it's fine if we're just have a heart murmur and I'm screening and I just want to make sure their heart's not great big and they're not heart failure. But left side, right side down, the left lung is what I'm seeing. So flip them over, you're seeing a whole new thing. Because a lot of times, if they have, what are we doing? If they have aspiration pneumonia, does anybody know what lung lobe is most affected on aspiration pneumonia? No, it's the right middle lung. It's because that's the first opening of bronchus. And so right middle, and right middle or right caudal lung lobe. I should tell you that the left lung has 2 lobes, the right lung has 3. There's a subsection on the left, but there's only 2 lobes on the left and 3 on the right. The right middle, could you see that if it was down and the heart was right there? No. And if it's really consolidated, you kind of make it out, but then you flip them over and you're like, oh, this whole lung is like infected. So with pneumonias, especially aspiration, but a lot of these Bordetella pneumonias or whatever canine cough pneumonias, they're right middle lung. So that's why we would want 3 views on a chest. And for MET checks, if we're looking for little nodules anywhere in the lung, we want to have as much information as possible. Next, Katie, abdominal landmarks. If you're taking an abdominal film, why are you
Don't carry your baby.
here? You're gonna stand her up.
I can't
Stand
see.
her up. Right, but if you're standing up, you can point to the 2 spots.
Girl. Katie. You gotta get up close and personal.
So, well,
Sometimes I wanna see if the urethra.
Depends on what you check.
if we're just doing abdominal films, the caudal landmark is the greater trochanter. Right here. Touch it. That's the caudal landmark, right here. That's the side of their hip. That is where I want when they're laying on their back, when they're laying on their side. And of course, you're stretching the legs back again to get it out of the way for the bladder and all that. That is the caudal landmark, the greater trochanter. Everybody know that, know how to feel it. If they're great big fat, you might not, but you still should be able to feel it. That's the caudal extent. Cranial extent, what were you saying, Katie? So if you feel the xiphoid, but if you took the x-ray right there, you're going to cut off the liver because the liver is also farther up. So the general rule of thumb is 2 or 3 finger widths cranial to the xiphoid. So depending on the size of the dog, of course. So if you lay them on their side and you feel the xiphoid, you basically, for this dog, if you did 2 finger widths up, you're going to probably get the whole liver. If they're a bigger dog, you might have to go a little bit more because basically this, because even though the sternum ends here, like I was saying before, the liver comes up like this. The liver comes all the way up to here, and then the lungs come back to here. So that's why you got to go a little more cranial to get the liver here, and then to get the lungs back here, you got to go a little bit more caudal, right? So that's how that works. So for this dog, I would probably go right to about here, about 2 fingers up. So just feel the end of the sternum, right?
Mm-hmm.
Well, 2 fingers from there to right about there. There's not an exact landmark. It's about that much, because that way you'll get the whole liver in. And if you cut it off, okay, we move a little bit higher. But that's a general good for a small dog. It's about 2 fingers. For a bigger dog, 3 fingers up from the sternum. And the same thing on BD. You have the same landmarks. To Nicole's point, off the butt. So we're generally not too worried about a dog's urethra, a male dog's urethra or whatever, but if they have bladder stones, we might say, I need a I need abdominal film off the butt. And that's because if you take it to right there, you will cut off the very back of the urethra, and we might be looking for a bladder stone, or sorry, a urethral stone that might be trapped in there. So we want to get the whole butt in there. But for an abdominal film, you don't need the whole butt unless we're looking for something in the caudal, abdominal, or rear end area. So for general collimation, it's the greater trochanter to where I said. But if we needed an off the butt shot, then you do that for lower urinary tract, or if they have a rectal mass or whatever that is. So those are the easier ones. Let's see. Skull films. How should a patient be if we're taking skull films?
Sedated.
Sedated or anesthetized, because skull is completely about perfect positioning and symmetry. The only way to tell if anything's wrong is if it's perfectly straight and symmetrical, because we're comparing sides. So they have to be very like dormitory sedation or general anesthesia in order to get a good skull film, or else we're just kind of wasting the client's money if we're trying to figure out if there's something there, right? So when we take a lateral skull, let's just say I just kind of want to look at the nasal cavity, or they got a swelling of the eye or something like this. You're gonna try to get them straight. But what you need to do to get a straight skull film is that when you have a dog on their side, you want to lay this dog on the side, like go on their side.
Okay, didn't see your drink.
Talk about this for a whole day.
Really? You? Never.
When we lay a dog down on their side and they're stretched, their head generally will tilt down towards the table. So you're going to have to put something underneath their chin so that their head is straight like this. This is going to be about straight. So you need to put something, gauze or a little towel or something underneath there so that their head is like this. When we take a skull film, we can tell it's straight because
Keep
the
going.
tympanic bulla, which are the little middle ear parts that are like little, I don't know, they're just little cups. Those should be aligned with each other. The jaws should be aligned with each other. So the two sides of the mandible should be aligned. And the palate should be able to be seen. And the hard palate is a nice white line. So if you have a nice white line, the mandibles are lined up and the bulla are lined up, that's a straight lateral. If they're not, you got to figure out how you're doing it. And more than likely, it would be off like this. It'd be pretty hard to take an x-ray the other way and have it, because you're physically having to roll them like that. So if you don't have it straight, you probably have to lift their head up a little bit more. When they're on their backs, it's you basically want to see a perfectly straight, everything's in line. It's a little bit easier to see, but the cool thing is if they're really straight, their ear canals you'll see their whole ear canal, and it'll show up with air in it, and you'll see that it's straight that way. So that'd be like for a VD skull and a lateral skull. We do open mouth VDs to look at the nasal. That's really important. And so we'll crank their jaw open and shoot down on their hard palate. That's to look into their nasal cavity, to look for tumors in the nasal passage or the sinuses. And so that's really an important film that we take very frequently for skull film. So you're gonna have to pull the jaw open, pushing their head down towards the table and shooting straight down on their palate. So if I say open mouth VD, that's what I'm talking about. And then oftentimes we'll do an oblique. So I want to show you something.
They left the scene of the crime. Hello, people.
If I'm trying to look at something in their mouth or some lesion that is on one side, and we're laying them in right lateral, we're coming to see, how did I just say that their head was gonna tilt, right? It's gonna tilt downward like this. So what you have to think of in your mind is that if their head is tilting down like this, right? Anything on here is gonna show up lower in 2 dimensions than on the other side. So if you put their head like this, her left eye is going to be lower than her right eye in the film. Her right eye is right here and her left eye is like this, right? So if I were to try to label this so I knew which side was which, because you can't tell which side is which on an x-ray when you have something oblique unless you label it, because it's 2-dimensional, right? So the way this is labeled is that you have an R over L. that means, so this is what I would ask you to do, is that you'd, on the machine, it's right lateral, but the right side is higher than the left side. So I would have you put the R and the L in the film like this, so that I know that anything on that's higher, whether it's the canine tooth, the eyeball, whatever that I'm looking at, is higher on the right side on the film than the left. So that's what R over L oblique would be. So it takes a little bit of thinking when you're doing that, but that's, when you look at it, you can see like, well, her left eye is here and her right eye is here. So if I take a two-dimensional film, that's what it's going to show up like. So we might ask for that. Those are some skull films. DV skulls are actually very common to look at the eyeball and nasal passage, etc. But those are some positioning for that. So then I want to talk about hips and stifles. So if you're going to do two-view pelvis, for whatever reason, maybe just looking for hip dysplasia only, the lateral pelvis is really not that helpful, but we do take, but everybody, if you can't see me, if I'm taking a right lateral, I want the right leg in front. So you're going to pull the left leg back, and you're going to try to keep it straight too, because I will be able to tell something about the knee if I have it like that. So the left leg is straight, right leg is straight and forward, and then it's a right lateral, right? And then as far as collimation, I mean, you want to get their, not only their hip joint, but their whole pelvis and maybe some of the lumbar spine. So for this dog, I would just take from like here back, right? So you're just going to collimate, and then I don't want their toes in there. We can get our knees in there, that's fine. You know, but you're going to take, so this is the lumbar vertebrae here. So you're going to take kind of right to about there, just getting the knee in there, all the way back to here to get the hip, the full hip in there. Plus we can cheat and get the knees in there a little bit. It's a great big dog. You might not be able to get the knees in there, and you have to take a knee film separate. But anyway, so that's a lateral pelvis. VD pelvis, again, they have to be very straight. They need to be probably sedated. And you're going to want to take their legs, pull them out, and turn them in. So I need to have their legs perfectly straight. They can't be frog leg. They can't be pointing out to the side. You have to manually, internally rotate their leg. So when she's on her back, it might be like this. I'm going to turn it in and pull it down straight. Okay. And then the same collimation, pretty much, you're going to try to get just a little bit cranial to the wing of the ilium. And you're going to get, you know, probably their knees in there. Most of the time, I feel like that's a good thing to get their hips and their knees in the same film, and it's not too, you know, open. It's not, you know, collimation's all right. You want to make sure that the pelvis, when they're on their back, their foramen are like this, right? If they're tilted, so let's say her head is towards my fingers, and the pelvis is like this. So I've got the two holes there. Let's say I have it crooked, and so this hole is going to show up nice and open, and this is going to be hardly able to be seen because it's shooting down like this. It's oblique. So these two holes in the pelvis need to be pretty much equal, and that's how you can partially tell if it's straight. So obviously you're looking at their hips, and they should be symmetric. But if you're trying to figure out, well, which, it's crooked, but how is it crooked? Look at the holes, their foramen in their pelvis. If one of them is great big and wide open, well, that means that you're shooting straight down on it, so you're tilted this way. And so you need to tilt them back this way. Does that make sense? Can you guys think of like? Okay. So then for stifles obviously doing my TTAs are very important. This dog is so nice. We'll have to get her treatment. She's looking forward to that. When we're taking stifle film, the affected leg is going to be down. Okay. So we're always going to have the, you know, if I'm taking the right stifle, it's going to be the one down like this. See how her leg is if I don't touch it? It twists this way. And bulldogs, Boston Terriers, pit bulls, they're the worst. They have very bull legs. So they are going to be really severe. Some dogs might not be as bad as that. So if I want a straight x-ray, I'm going to have to twist this down, right? And see, look at the tibial tuberosity. You can even see that. but sometimes it's even more than you think. And so you might do it and like, it's still not as straight as you think, and you
Right.
really have to twist it more. But one thing we have to do, we don't want to pull it too high.
Hold
You
on.
just, you go ahead, baby.
So you want to
Hi, team.
hold the stock up off the table a little bit, but not too high, because then the femur will be not straight. So you want to, twist it down like that. And then the angle, like I don't want it bent and I don't want it straight. I want it just like that. I just want it kind of natural. So like this, about this bend, it's about 120 degrees, 130 degrees, not flexed and not overly pulled out straight. Just how it sits kind of naturally, maybe with a little bit of a flex when I do that. That's how I want my stifle film.
Parallel to our view, they're back foot right here, should it be like lined up to our viewing window, is what I mean?
Yeah, I mean, it doesn't matter so much. If you're, however, I see what you're saying, like, that's great, but if it's, because you kind of have to, like, especially if it's a big dog, they hardly fit into our viewing. So however, I can always rotate the picture that I'm looking at.
Okay.
The most important thing is that the knee is straight. When you have a straight knee, Nicole, how should the fibula look? The little bone. Yeah,
Right on top of the other one.
no. You should see the
The whole.
You should see the fibula. If the fibula is overlying the tibia, that means it's like this, because the fibula goes off the back of the lateral tibia. And if you're shooting like this, then you're not gonna be able to see it. If I go like this, oh, I'm pulling it back around, and you should see a gap between it. And that's one way to know that you're straight or close to straight. Then the top of the tibia is like a heart. You got the two surfaces here like this. It looks like a heart. So these two sides should overlap each other. If I have it not straight, I'll see one back farther and one up. So in order to know that it's straight, those two should be aligned. I should see the fibula coming right through here. So you have this gap in between. That's how you know the tibia is straight. But then the femur should be straight too. How should I, Marla, how do you know if the femur's straight?
How do you know if
If I got a straight view of the femur lateral, what does the femur have at the end?
the head? I mean, not the head, but what's it called?
No, the femur. It has
I'm
the
not sure what
condyle.
you're asking.
It's got
Oh, okay,
two
yeah.
condyles, those two round things.
Yeah.
Same thing like this. There's two things, right?
Yeah.
So if you have two things that are supposed to be symmetrical, when you do an X-ray, they should be right on top of each other.
Mhm.
If you have one like femoral condyle, you see the semicircle, and then another one, then the femur's not straight.
Like
More than likely, it means you're probably picking up the leg too much, but maybe not. So you left.
All right.
So it's really important when you're doing a knee film to try to have the femur pretty laterally straight and the tibia straight, so that we can evaluate the joint space the best. But also, if I'm making measurements, this has to be really straight, especially if I'm taking post-operative films. They really have to be straight, because I want to know if I put these in well, and if it's not straight, I can't. It'll look crazy. Like if I take an X-ray of this leg, like this is a left tibia. So let's say that I was like this. I mean, this cage is gonna look like I put it in sideways. It'll be like this. And this will look all crazy. And so the only way I can really evaluate my work is if it's really straight for this. It's specifically the tibia. Okay, that's pretty good. I mean, we have more stuff to go over.
I don't,
extremities.
can somebody check the schedule, see if we have any twos?
Okay.
We're good to keep rolling.
Someone help me pull some catheters.
Okay.
It's my first one. maybe in
Extremities.
Half an hour.
Oh,
Ex-
yeah.
Extremities, sometimes they have to use tape to pull their little toes out. When we do forearms, you're always gonna have it be an AP for their forearm. And then for their elbows, often we'll also do just an AP of their elbows. You can pick their head up and pull their arms out so they can get straight down. Doing on their back is typically for their shoulders. To do a PA, we're gonna do a PA. There's no way you can get a shoulder from a. No. So you pull their arms over the head and you scoot down. I think the hardest film to do is a lateral shoulder. When you do a lateral shoulder film, in order to not have the lung in the way, you almost have to have them in VD. Like they can't be on their side. They have to be almost on their back, and then you have to kind of chicken wing their arm down so that, and I'm not gonna do it, her, and that's why they need to be sedated. But they're almost on their back, then you chicken wing their arm down so that you can actually get the shoulder joint. Because otherwise, if you just have her on her side and you pull out their arm, their chest is gonna get in the way, and it really is hard. You can't look at the shoulder if you've got a bunch of lung gas and all that stuff in the way. Especially if we're looking for a tumor on the top of the shoulder, you can't see anything. So you gotta almost have them in VD and pull their arm down like this. The other extremity views, I mean, are pretty self-explanatory, like, you know, for a lateral and a AP. I mean, they're not too hard. Just you have to use tape usually to hold their foot out straight, but you just want it as close down to the table as possible. What am I missing? Does anybody have questions, or is there something I need to go over?
Show how you do the post-op TTA.
Well, the PA is somebody has to hold the dog's weight here. Yeah. Somebody kind of has to hold the dog's weight, and then you pull their leg down, but you know, let's push her down into like.
Bubba's, hold on, she's got this leg out. There you go. There you go.
All right. So if it's a big dog,
Hey, sweet loves, I got you. I'll give you a here. Here, baby girl, lay down.
She's been doing it really well.
You have to do it, loves.
right.
Lay down.
so if I pull her leg just straight back like this, it's not straight. It has to be up underneath her. So her weight actually has to be like this way. Because if she was like this, like that's not straight. She has to be like this. So the dog will be sedated or anesthetized. So somebody's holding up their weight and I pull their leg, but they have to be kind of like this. So the leg has to be straight underneath them like this. And then she would be down closer to the table. So her knee would be fairly close to the plate, but it has to be like straight underneath her. So in order to do that, you have to kind of like tilt them this way so that the leg is actually straight. Because normally when a dog's leg goes back, it's kind of like out to the side. So you have to kind of like tip them over a little bit and go like this.
Same rotation of that.
You got to rotate it inward. Yep.
Okay.
So you got to rotate it this way, and pull it down straight.
Okay.
And then all I care about is, well, you gotta make sure you have the femur, but just getting down to mid tibia so you get the screws on there. If you
Okay.
come a little bit past that, that's fine, but basically when I'm taking a knee, I want mid shin and I want mid femur.
Okay.
So you get a little bit more time, but we want to have this area when we're taking knee films for anything. What else? For image, for positioning. But the shoulder one is really challenging. I mean, there have been times when I've like had to take so many films just trying to get the lung out of the way, but really it's about almost getting them on their back and pulling out to the side, and they have to do together. I would say chest and abdomen films are pretty okay in most patients to do without sedation, but if you're taking skull films, it's a must. If you're taking orthopedic films, it's typical. I have had some cooperative patients that let me take knee films, but their knee hurts and I'm trying to get that VD, like before surgery, like if they've torn in their ACL and I'm trying to do a VD pelvis and stifles and get them both in there, it hurts to pull their leg out that way. So, I mean, if they're not too painful and they're allowing it, then we do it, but usually I will sedate them. And obviously if a dog is really hard to get a VD on for an abdomen or something and they're well enough, we should sedate them. I'd say 75-80% of the time we should be sedating our x-rays, but there are cooperative patients or they might be too critical and we can't sedate them. But if they're critical, anyone will tell you we shouldn't be x-raying them until they're stable. Nobody should die in radiology, right? If they're breathing heavy, we should be able to figure out what's going on to help them first, at least like get a good kind of idea of what's wrong. And then once they're a little bit more stable, we can take an x-ray to see what needs to be done, but we shouldn't be taking like a really dyspneic patients to radiology until they're stable.
Are you gonna do two of them?
Oh, I totally forgot something really important.
Yeah.
This is a really important one. 3-view abdomen. So this goes back to the chest thing. 2-view abdomen, 3-view abdomen. Why might I want 3 views? So 3-view abdomen, sometimes it might be, because there is something that we want to see, like maybe I didn't know that the right kidney was huge. And I took a right lateral and I can kind of see something's not right with it, but it's underneath a bunch of gas and all this stuff. So I might flip them over and do a left. But the most common reason we want a 3-view abdomen is because we're trying to determine if they have a foreign body obstruction. Because I would say in my experience, 7 out of 10 times, whatever they ate is not very visible on X-ray. It's not like, oh, there's the foreign body. It's like some piece of underwear or sock or some crap that you can't see very well. So what we're looking for is gas. Well, when you move, if I have an animal on their side, where's the, like, my left hand's the bottom and my right hand's the top, and where's the gas? Up, right, and then so we're trying to get the gas to show up. So if we're not sure if something's really dilated, we might flip them over. And then, oh, there's more gas over here, and it's worse because of where the positioning is. So flipping them from right lateral to left lateral helps us see the gas patterns because we're moving the gas and the fluid around. A good example is in the stomach. So our stomach, the fundus is on the left and the pylorus is on the right, right? So if we have right lateral, so if this side's down, well, the gas is going to be in the fundus and the fluid will be in the pylorus. And that's how we normally see like the nice stomach view. But then if we want to flip them over to see if they have something in their stomach, we might, then the gas is going to be up here and all the fluid will be down here, and we can see the pylorus better when they're in left lateral, and if they have an outflow obstruction. Another time would be like a GDV. A GDV, you should never do a VD abdomen. You just do a left lateral and a right lateral, and I'll tell you. Because you could usually see it on a right lateral only, but if you flip them over on the left and the wrong thing is full of gas, then we know it's flipped over. Putting them on their back, it causes too much cardiovascular compromise. So if we were trying to diagnose a GDV, which I feel like we hardly ever see, we do a right lateral, and if it's a slam dunk, great. If it's not, we flip them over and left lateral, and it'll tell us if it's flipped or not, because we're flipping gas around. And if there's gas on the right lateral in the pylorus, then it's flipped. If this side is down and there's gas in it, then we know it's here, it's on the wrong side. So that's why doing 3 views is why we normally would do it, is for foreign body obstruction. If I just said I want to see if you got a big liver, or they've been vomiting, just want to check for pancreatitis or something, or checking for a splenic tumor, right lateral and the VD is generally good enough. But sometimes we might ask for 3. So really, the only reason not to do 3 views is, well, there's 2 reasons: cost extra money. So if it's really not needed in the client, and we're trying to save their money to do whatever we need to do for treatment, but then also exposing them to an extra views. So I'm going to wrap it up with that and just say, in summary, what Nicole said at the beginning is about, if we can take good position films and not like have to take a bunch of films and just keep doing it, we're exposing them to less radiation, we're exposing ourselves to less radiation, we're getting better quality views that we can charge clients for and say, this is a diagnostic image, and not some crappy, bad positioned catagram that doesn't do any good. I mean, that we're charging people for. So a good position X-ray is really critical to our diagnostic potential, for safety to everyone, and for the value for the client. So that's why if we try to be sticklers about it, it's because it's important, and then the more you practice, the better you get at doing it. So, any questions? Okay, I'm probably gonna do this again. Oh, good. I'll probably do this again. Well, you have to. Come on, you do. So, good. Thank you, everyone.
Thank you.
Yes, thank you. All right. All right, guys. It's a wrap.